and you can try to get it as close as possible. And now let's say that you do it and you go, wow, I mean, that custom healing abutment that I milled out before we did anything is really looks good. Now I want to make it into a temporary. You already have the information, right? You already have the emergence profile. It's already a digital file that you could do an impression to just basically get a scan log of the implant position, and you now marry those two files and you just add a tooth to it and you're done. So it's really, the digital workflow makes things way more efficient, and as we said yesterday, accuracy levels can go up because you can reproduce something that you have in the mouth 100%. For me to be accurate from the mouth to the lab bench requires my hands and my skill set and my technician's hands and skill set. But you want to up the accuracy, digital allows you to do that.
Yeah, and the future is, again, I was involved as an author in a paper looking at the concept one abutment, one time. And it's based on these concepts. So Gerhard Egelhaut and some others involved in the paper, in a perfect world, you don't want to connect and disconnect a bunch of different times because that negatively impacts the tissue. So in a perfect world, you get the abutment on at one time. It could be the final abutment, right? So that's now going to the nth degree as far as planning and so forth. Can be risk involved with that, but maybe the future is guiding us more and more to those.
Yeah.
In this image over here on the left side, from an aesthetic standpoint, I'm a little bit more concerned about the distal aspect of the implant and that papilla than the mesial aspect. And I'm just kind of wondering, what are your thoughts about what options you have? Like, is the scarf graft something that would help with that papilla? I mean, is there something else you would do? The symmetry between those two papillas is pretty significant.
Yeah, so there's been attachment loss on the mesial of the lateral. That's what he's noting and picking up, which when you get added contour here, this papilla will move, but I'm anticipating it maybe moving only this far, okay? Maybe. But again, if I look over here, I see that I'm deficient. So in this case, I probably wouldn't do much because I'm deficient on the other side. But if in fact we had a situation where we had a unilateral papilla loss because of attachment issues, and typically what this is also associated with then is facial attachment loss, so you'd have recession on the facial, that I know what Jim would do is he would do the scarf graft, or he would take connective tissue over the ridge on this mesial aspect and he would tuck it underneath on the facial to be able to enhance both of those areas. But in that regard, now we're going to an augmentation as opposed to a support. So we would put a smaller healing abutment on here, and he would try to get more soft tissue gain over the entire aspect of it. But you're exactly right. If we needed to get more gain, this wouldn't be the choice for the abutment, though. It would be put something small on to get way more soft tissue. Yep.
So one of the simplest ways to look at that, of course, looking radiographically and idea where the bone is, but using a periodontal probe and probing sulcus depth. And if you probe sulcus depth on this side, let's say it's 3 here, 3 here, 3 here, and 1 here, then you have a sense that by shaping the abutment right, you'll get some coronal movement of the tissue. So that's a simple way to have a good sense of what might happen as well. Radiographic bone level, and then sulcus depth is going to be key. Just one more question.
Yeah, I have a
yep.
quick question on that, the last photo. When you see those triangular
Yep.
shaped centrals, like whenever I see a patient with like a hopeless number 8 next to a triangular shaped number 9, it's almost like I'm setting up the patient for a veneer on the tooth next door too, because I'm always concerned that's going to really set me up for a black triangle. Do you often go back with composite if you're not able to kind of have the water balloon effect that you want on that, pushing on that papilla? Would you go back with direct composite maybe on the?
Yeah, so great question. And again, this goes into the pre-prosthetic planning. I want to look at all aspects of the case before I start. And one of the things that impacts us quite a bit is trying to fill up an embrasure space is we have triangular shaped teeth, which we can see from day one. And we know that there's going to be a problem. Maybe there's already a black space before you take the tooth out. or maybe the papilla is going to fill it with the tooth intact, but when you take the tooth out, you know you're going to lose it. My typical protocol is, unless it needs a veneer because it has other aesthetic issues, this is going to be direct composite. So just a mesial composite, and I have all sorts of access to be able to put it on. But I will tell the patient that from day one. In fact, the last case I'm going to show you was similar, where it's going to have a mesial composite in place. If it needed other aesthetic work, then it would be a veneer, but otherwise, no, it's going to be minimally invasive, just direct composite. Just take a strip, roughen, clean the area, and then freehand some composite. Yeah, good question. Okay, so that kind of leads us into the immediate provisionalization. It's a great option. What I don't know, and I can now take it to the point where you're seeing the patient restoratively in your chair, you're going to anticipate the tooth's going to be lost, and now you're talking to the patient about how are we going to replace the tooth in the interim. But you haven't had the patient see the surgeon yet. So I tell them about options. One option might be that we take the tooth out and either the surgeon or myself makes a temporary on the implant. But what I don't know is, I don't know how much primary stabilization the implant is going to have. That's not being able to be identified until the surgeon actually places the fixture and sees how tight they can get it in the bone. So I put it as an option, and then I follow it with another option. I say, we're going to do something probably in this realm. You'll never walk out without a tooth. You'll always have a tooth there. But then I leave it up to the surgeon to decide. Right? Now, if we're going to do an immediate implant provisional, we're going to be using one of these 4. I'll actually say probably one of these 3 to fabricate it. Jim will sometimes use an existing crown, as long as you can get the crown and hollow it out without destroying it. So that means it's typically a metal ceramic crown. The problem I find with doing this is it's typically ugly, and why would I want to make it ugly when I can actually make it better? So I either use the natural tooth, if it's a good tooth. I use a Copyplast or a putty matrix. I like to use putty, I like to use Copyplast, Jim likes to use putty. I like to see what I'm doing. He just likes the accuracy of using the putty. Okay? So how is it done with a natural tooth? So this is a case where Jim is going to be treating this central. And the reason that the central is going to need to be extracted is that it has a fracture. Okay? Now this is also a triangular shaped tooth. So I would have the discussion that if we lose this really super good papilla and it starts to go apical because the contact point is so coronal, we're probably going to want to do something onto the mesial of the other tooth. Right? And we'll make the call of what that is. We might do it as composite. Okay? So the tooth's going to come out, and he's going to try to take it out and maintain it. And in this case, given the obliqueness of the fracture, he's going to basically have to use it as a veneer. It's going to be an enamel veneer, an enamel shell. So yesterday when you're working on your model, I think you're at the point right now where you're using an index to start to hold it. You're getting there?
Connected it to the metal opaque abutment, so we're just working on contour.
Okay, so you've used the index to help position it.
Yes, the index on the inside,
Okay.
which will show.
So you used an index yesterday to hold the little shell of the tooth to get it in the right position, right? And you did it on a model. We're going to do the same thing now. We're going to do it clinically. Because if I had to position that over the implant, it's just a shell. So I could put it in 1,000 different positions. I want it back in the position that it was in before it was extracted. So using an index as a carrier allows you to reposition it ideally. So this is going to be the index. So what this is, it's going to give Jim a surgical guide, but then it also engages onto the incisal edges where you could take that extracted tooth and you could stick it into the incisal edge here and reposition it. So it's kind of a dual purpose. It goes to the incisal edge so he doesn't lean it too far facial, and then he's using, as far as his depth, he's using the gingival margin of the adjacent central. Now look what's happening to the soft tissue. We saw the canine. I showed you how nice the papillas were, and I said that if you sat and watched it, it would in fact do this. you would start to lose the papillary support and they would start to slump on you. In fact, even this tissue here is going to start to fall palatally. So before the surgery, you can take a stock temporary abutment, an engaging temporary abutment, and you can opaque it. Whether you use colored opacers or whether you use an opaque composite, doesn't matter. But now you're going to take your soon-to-be provisional, your enamel shell, and you're going to hollow it out. And I would typically either remove all of the cementum, or if you're going to leave a little shell of cementum, you don't want it to be cementum back in the mouth. Because what will happen is when you get it relined and you put it in, the tissue is actually going to attach to it because it's actually tooth structure, right? Cementum. And it'll look phenomenal in the provisional phase, but when you go to take it out, it's going to bleed because you have to sever the attachment, and then you're going to change the support of the soft tissue. So either remove it completely, grind it off, or at the least aerabrate it, etch it, and put some resin on it. So now it's root, but it's covered with resin, so you won't get a true attachment to it. So now what the shell is going to be used for is you're going to set it back in the index. And it's not going to stay very well, right? So take a little bit of bonding resin and set it in there, hold it, put some bonding resin or some composite and cure it so it actually stays in, it doesn't wobble around. And you're going to seat it over the abutment, which means you're going to have to take these little papilla and you're going to have to move it to the side as you take and put that in. And then your job is to add composite and stick this to the abutment. And once you get it stuck to the abutment and you pull it out of the mouth, this is how much thinking you have to do. This is your emergence profile. But all of the points are there because you know the tooth contour that you're trying to achieve. So it takes the thinking out when you have a preformed shell or, like this, a tooth. And now it's going to go back in the mouth. And again, look at the black spaces that are present. Just in the short time that it took to do that, the tissue height has been lost. But it's lost because we have no support. Now we're going to give it the support back, and we're going to leave the space because this tissue now is going to start to move coronally once again.
So relating this to where we finished yesterday afternoon, right? We used our bisacryl tooth, we connected it, but we were working on the model. We created that funnel by grinding on the tissue, and most of you found that you probably didn't grind enough of the tissue, so now you're under contoured. So now the next step we're going to go through is freehand addition to create the ideal shape, but this is now based on conceptualizing how that's going to support the soft tissue. So whether it's in the mouth or on a model, or actually what we'll show you late today, whether it's on the computer and you're designing it on the computer, it's all the same thought process, same understanding. What we're trying to do is create a shape to support the soft tissue.
The reason we do the delayed approach for you first, because it's the most thinking, it's the most challenging. If you can adjust soft tissue, which as Bob said, I typically underdo it, and then you have to add the contour back. When you add the contour back, you're basically doing this. If you can do the delayed approach that we are doing with you, started yesterday, this becomes really, really easy. So we give you the hardest one first because it makes every other piece that much easier. Rodney.
What's your timing window on this?
To fabricate the provisional?
From the time they do the surgery?
Yeah, good question. We would typically do this either at the day of surgery, during the day of surgery, or the next day. That's our typical window. I think you can go 48 hours, but 24 hours for us is kind of our window.
Sometimes the surgeons sedate people, so they can't get to your office that day.
Right. So let's take his question and we'll take it one step further. Let's say your surgeon doesn't want to do it, right? They don't have enough time. They got a bunch of other surgeries, and what they're going to get paid to make the temporary for you isn't worth their time and energy. So you're going to do it. But you can't see them the same day because maybe they had some sort of a medication, so they can't get to your office. How would I fabricate it? Imagine taking an index. Remember this right here? Once the implant is placed, use this index and stick an impression coping on the implant, right? And lock it in place. And you're going to do this.
We will actually do that. In fact, I was just going to have you come back to this image because we made this index, and I said if the restorative dentist makes this before surgery, it saves some time. It can be used multiple ways. And then Greg is even showing how Jim used this as a surgical guide. The problem with this is it doesn't show you the soft tissue, so you'd probably have something else to show depth, or it's based on experience. So this, we will actually do the exercise. We'll actually lecture about it as well and talk about indexing the position of the implant. So then as the restorative person, I can get that same day of the surgery. I can make the model.
Okay, so let's, one sec. Imagine now they hook an impression coping to the implant and now they secure it with resin to this. So when you pull this out of the mouth, it's your index that fits onto the teeth, and in it is an impression coping. And they're all hooked together. It's like one big piece, okay? They send this to your office, right? You go have a staff member pick it up, or they send it to your office. So that night, you take the original model, you drill a hole, like you're extracting the tooth, drilling the hole out. You can seat this on the model, and you can put an analog on it, and you can lock an analog onto your stone model. And then if you had the tooth from the day before, you do exactly this on a stone model, which is kind of the way you're working right now.
Yeah, exactly.
Next door.
And we will do that. Again, we will do it by, tomorrow afternoon we'll finish that exercise. And the point being is you can use simple tools to allow you to do things. I like to think of non-chair time. There's less stress involved. Quote, it's less expensive because chair time's expensive. And you have the capability of adding, subtracting, and so forth without the stress of, hey, the patient's numb, it's wearing off, and so forth. So you're buying time and less stressful.
So when you bring the patient back the next day, you could have this provisional already done. You're just doing it on a model. And again, I alluded to this yesterday morning when I began, by saying that we're going to be working on models, and sometimes it's a model and sometimes it's a patient, and sometimes the techniques can go either way. You can do that same technique on a model or a patient. So our goal is that things make sense to you, that you know when you can do one versus the other and how it would play out. But you'll do this procedure, you'll actually make an index, and you'll actually seat an index and lock an implant or an implant analog into the model. You'll do all that, and I'll show you that again as well. I was going to say something very important, but now I forgot what it was. So let's say that you do this and you bring the patient back the next day. Why don't I want to wait longer than, let's say, 24 hours? It's because you get bony change around the fixture. And as you wait longer, the implant, although it might have good primary stability the day it's placed, it will start to lose some of that primary stability. So when you go the next day to put your implant abutment and temporary on, you're going to want to stabilize the tooth. Because and I only hand tighten these, I only hand tighten any provisional restoration. You're going to want to hold on to this, because if you were to start hand tightening it, you could have the entire tooth and the implant start to move on you, right? Because you're having some change around the fixture. So if you wait longer, that's the risk. So 24 hours is kind of as long as I would want to wait. Bob, would you?
Exactly the same.
You use the index to stabilize that where you tighten it in?
You could.
Yeah, I use this index. But you could put the index back on and actually tighten it with that in place, for sure.
So in little things that we try and share with you is, again, making that index before on a model. And so if a surgeon does it directly on the teeth, there is a risk that it's not going to transfer well to a model. So that's why my bias would be make it before, because I know it's going to work on that model. You can confirm it's going to fit in the mouth most cases before the surgery, so you know you're not introducing an error. So that's another little tip that I try and think of.
All right, another clinical scenario. Let's say that your plan is to do an immediate temporary. But I told you that you don't know how good of primary stabilization you're going to get. And who's going to know that? The surgeon, right? So let's say you plan on doing this, but you get to the day of surgery, they take the tooth out, they put the implant in, and the surgeon goes, you know what, I can't get it stabilized enough, I can't make an immediate temporary. Now what do you do? Well, I always want to send with the patient a backup plan. I always want to have a backup plan in case I can't do what I set out to do. But I don't want to spend a lot of time and money on the backup plan. So the easiest thing to do is you send them a clear Essex that you snap over the initial model. So as a backup, if you had to, they could use that clear Essex and fill it with provisional material and do a custom healing abutment, and that's a quick interim temporary. It doesn't cost you much to fabricate, doesn't take you a long time to fabricate, but it can save you if in fact you can't do what you set out to do. Now, if you don't use it to do it a temporary, I'm still going to have the patient use it. Because I told you that I need to remove contact. I can't have the patient functioning on that. So I have to change the incisal edge and I have to grind on the palatal. But I still won't trust the patient. So they actually wear the Essex. And the reason that I'm having them wear the Essex, it's a reminder that there's some dentistry that was just done. But when I fabricate that Essex, I actually put a little bit of spacer around here, right? Because they fit really well. And you imagine they snap it on and off and they pull it on and off throughout the day. That's a lot of stress and movement you're putting on here. So if I give a little spacer, it's fitting intimately everywhere else and it slides on and off a little bit easier. It doesn't put the same stresses on.
So think about that. The backup plan is an Essex to put a tooth in, but I would personally do a second Essex with the spacer on, because if I put a bisacryl to give them a tooth and all of a sudden now I've spaced it, now it's a bigger tooth. So think about that. Again, it's pretty inexpensive to suck down another one, right? Almost no time, a few bucks for the sheet, but think about that as options as well for you.
Just don't put so much spacer on.
Yeah, I want to pass the fit.
Okay, so you got to check occlusion, you got to make sure that they can't get on it, and you have to instruct them, and then as a reminder, the Essex actually helps them keep from functioning because there's a piece of plastic in their mouth. Now I want you to watch what happens to the embrasure areas and the papilla heights as this starts to heal. Okay, so here's the contour, this is the thinking, and this is kind of where you're at next door with your restoration. I will almost guarantee you that you're under contoured in what you adjusted on the soft tissue. Why do I say that? Because I would be under contoured. So now you're filling in this area next door. You would do the same thing clinically here. And now look at the papillary areas as the patient starts to heal and mature. Okay? So we have really nice papilla areas. And if you look at the facial gingival margins, it's not a huge change, but do you see the deficiency now compared to this gingival margin roll versus that side? You see how it's flattened out? Doesn't have the thickness here? So Jim is going to come back and actually do a connective tissue graft to plump the area, and in the process, he's going to do what I showed you on the very first case this morning. He's going to drag it over and cover the root on the lateral. So now the facial connective tissue graft was done as a second surgical procedure, and here is everything healed and ready to go to final restorative. Okay? Now, from restorative dentists, you're going to run into a problem, right? When you use natural teeth that look good, your technician now is going to be very challenged trying to improve upon nature, right? I mean, even in provisionals sometimes, we can do things in provisionals because of the translucency of provisionals that you can't emulate with ceramic materials. You have opacities and shadows that are created. So technicians can start to be very challenged trying to now turn this into a final restoration. And you'll often hear the patient say, well, why can't I just keep this? Right? Or you'll make a provisional, and then I've had patients say, well, why don't you make the final crown? You made this, it looks so nice, why don't you make it? I said, no, you don't want me to do that. Okay? So if you have a good looking tooth, or you have an ugly tooth that matches the ugly tooth next to it, as long as you have the form, this is a really good option. Okay? So how, if let's say it was a resorptive area, maybe an ankylosed area where the tooth looked good, surgeons, how are you going to get that out and keep the crown form? What Jim will do is he'll take a burr from the back of the tooth and he'll start to cut horizontally towards the facial, and then he'll take and he'll snap the tooth off. And he's fine cutting from the palatal because adding material there is not going to be an aesthetic, and it's not really so much of a contour issue, but he'll try to preserve the aesthetics of the crown by cutting it off horizontally. Okay, so if we can't use a natural tooth, then I'm going to rely on some sort of a copyplast matrix or a putty matrix to give me the tooth form. Okay, so this patient comes in to see me. I get a lot of second opinions, but sometimes I get them really late in the game. Like they're going to have a procedure done next week, and they get appointed to see me a week before. And I'm like, well, you already have your team in place, and you already have an appointment scheduled. So, I mean, what do you want from me? I said, so what's going on here? So she gives me her history. That the anterior teeth have continually started to flare, right, and open up a space. And so as the space opens, she doesn't like the space, so the dentist would add composite. Close the space, pretty soon it would open up some more. They'd add more composite. Now in the process of adding the composite, maybe the contours subgingivally weren't ideal, so they started to create a ledge. And the ledge they create now is a trap for bacteria and plaque and calculus, and all of a sudden you start to get a vertical defect on the tooth. And it's still starting to move facial. So what they said is, we're going to take the tooth out and we're going to do an implant. That was her plan. It was going to be set in place the following week. And you know, patients are they're very logical. I said, so you're telling me that this tooth has been moving, and they add material and they have a big bony defect, and so they're going to put an implant in. But the problem is the implant isn't going to move, which means that as the process that created the issue continues, you're going to have a bigger problem, because that implant is going to break, come loose, ceramic's going to chip. I mean, something is going to happen structurally because it's non-adaptive. I said, what would make more sense to me is let's fix the problem that got you in this situation. And if you look at the way her lower anteriors are set, stepped above the occlusal plane, crowding, tight anterior relationship, that's the problem. And the problem was exacerbated by the clinical treatment that was done to accommodate the problem. So a better option would be, let's not take it out yet. Let's do ortho. Let's fix the primary issue. Let's correct the malocclusion, right? You know, when you start to have patients where teeth are moving, you start having diastemas open up, it's telling you something. There's a reason why that's happening. And a lot of the reasons we say nowadays, I mean, you could say this is because of the malocclusion, but it might be that they keep wanting to move forward, because if they move forward, they can actually breathe easier. So it's a functional issue. It's a breathing functional issue, not a tooth functional issue. So my plan is, let's do ortho. If it was me, I would say let's do ortho first. And let's clean things up, because there's a lot of subgingival localized factors. And in the process of doing the ortho, we can also erupt that central, and we can improve that vertical defect. Now, I told you yesterday that when you erupt a single tooth, you improve the facial bone and facial soft tissue. You don't improve the papilla unless you erupt the tooth adjacent to it. However, in this situation, when you have a vertical defect and you erupt the single tooth, what's going to happen is the vertical defect, this is kind of what it's going to look like, it's going to improve to the level of the bone on the adjacent central, right? It's not going to do this once you continue to erupt it, but I can actually get rid of that vertical defect. So that's our plan, and she says, well, that makes total sense to me. So I send her to the orthodontist. So John Moore is going to be my orthodontist. He erupts the tooth, he's cutting it down, he's aligning the arches, he's improving this site for maybe a potential implant, and he's improving it from a biologic standpoint. He's removing the probing depths and that vertical defect. Okay, so this is now post-ortho. And if you look radiographically, now we have more level bone. I don't have the longest root, though. But I said that now we would reevaluate. So you could take the tooth out. You have a good implant recipient site. You have bone and tissue more coronal than you need it, which is good because I can control the apical movement. Or maybe you decide to keep it. Right? I can always take a tooth out later if I needed to. And we always get caught up on having a 1-to-1 crown to root ratio, which we don't have here. But there's nothing in the literature to say that you have to have that. So if I look at the amount of root left in bone, and if this was my mouth, I'd probably think of keeping it. Now, what would that entail? It would entail facial crown lengthening, right, to move and reposition the hard and soft tissue to emulate the gingival margin. My papilla is probably going to be a little bit deficient compared to that side, but not too bad over here. In fact, if you look at where the pulps are, I probably wouldn't even have to devitalize this tooth. If I prepped it, I probably still wouldn't be into the nerve. And I think that this would be a long-term, really successful tooth. Now, that being said, you know I'm taking this tooth out, right? Otherwise, I would not put it in this workshop at this moment. Okay? But I spoke with her about taking the tooth out, and her response was, this tooth has been a thorn in my side for many years. You have no idea what I've been through. I just kind of want to move on. I want to part ways, and I want to forget that section of everything that's happened, right? So we're going to take it out. We're going to do an immediate implant. We're going to do an immediate provisional. Now, I'm not going to use this tooth because it's kind of ugly. So I'll take an impression of that, and then on a model, I'll do a stone ectomy, and I'll wax up the tooth form and kind of match the adjacent tooth. And from this, you could actually make a putty over it, or you could duplicate it, pour it in stone, and do a copyplast matrix, which is what I'm going to do. So this is the day of surgery. Bobby Butler is the surgeon. He takes the tooth out. He places the implant. And again, it just kills me to look at this tooth because I think that's a viable tooth long term. But here's the situation. And the nice part is Bobby actually brings her over to my practice. And coming from downtown, maybe 15, 20-minute drive. So he actually hand delivers her. Thought that was really a nice touch. All right, so what do I have ready? Much like I showed you on the previous case, I have a stock temporary abutment, and on the previous case that was opaque composite. This is just composite opaquer, like a Kerr Color Plus opaquer or the Estelite Color Opaques. This isn't the stock screw that comes with the temporary abutment, right? Because that temporary abutment screw is somewhere down in here. This is an impression coping screw, a long screw. I put it in so when I slap on my copyplast matrix, I can see where the screw is going to come out, and I use this screw to fabricate the provisional. If you didn't use this and you use the temporary abutment screw, that's fine. You'll just have to make a mental note of where you're going to have to drill to get down through the temporary into the screw. So all I have to do is keep this semi-dry, semi-clean. I'm going to put some adhesive on it. I'm going to fill up my copyplast matrix with Bisacryl, and I'm going to seat it just like that. And the screw is going to come right through my copyplast. And when it sets and I take it out of the mouth, this is what I have. Now this is kind of taking what you're doing next door to the nth degree. I've really under-contoured this. But if you think about it, all of my landmarks are there, right? I know where the gingival margin is. I know where the papilla heights are, and I have my tooth form. I also know where the head of the fixture is. So now, out of the mouth, I can clean it. I can add more adhesive, remove the flash, and then in my hand, I just freehand and add in composite. Yep.
Do you find you have to use like Teflon tape or Vaseline in adjacent teeth, and do you ever have an issue getting it locked?
The only issue that you may have, and you wouldn't have it here because you can see no material came apically because of how thick the soft tissue is, but surgeons that are doing this day of surgery where you have a smaller diameter implant in a larger space, let's say a central, is that you have the risk of this material going all the way down to the head of the fixture, going too far apical. It's not going to stick to the adjacent teeth, but it could go down around the fixture, which is not something that you want to have happen. So what Jim will do is he'll use little collagen, like a little Colacoat, and you can either cut strips of it and put it around the head of the fixture, or you could even make a little hole and put a little skirt around the abutment, so that when you put it on, it has a little bit of a natural collagen barrier that prevents the material from being pushed too far apically. You just take it off and throw it away when you're done with it, but it can prevent the material from going down. So that's especially that when the surgery is being done, you have more chance of the tissue or the material going apically. Given that he did the procedure, brought her to my office, now it's probably an hour after it, so the tissue is kind of feeling more tight around it, so I didn't need to do anything like that.
So when I do immediate placement and immediate temporization, of course I'm grafting that buccal gap with bone graft, and I usually put a stock healing abutment on to hold the tissue somewhat while I'm
Yep,
whittling
yep.
things outside the mouth. But should I be concerned about flowing apical to the collar now that there's a graft there, blood's formed, the clot has stabilized? I mean, when I pull it out, I don't see anything physical, but is there?
Well, so you have a barrier it's a different barrier. You've put your bone graft barrier, and depending on the timing, you have a blood clot that might be formed or semi-formed in the area. So that's now your barrier. But there are times where, yeah, it's a real concern of mine. But it's a real concern when it needs to be a concern. If you have something down there, then maybe it's not a concern at that specific patient. But it's something to always keep in the back of your mind that if it goes down, it has no restriction. It can go quite deep. And if you left anything down there and didn't realize it,
Yeah, that would be my concern, is not necessarily leaving some of the bicicryl, but just the material contact to bone graft or tissue. You have resin now contacting those surfaces. There is going to be some molecules left behind, and that can negatively impact healing. So I think the safer approach is what Jim does, is put the Colacoat there, because I would say you would want to avoid resin uncured resin contacting any surgical site like that. And granted, it is hitting the papilla and some soft tissue, but we deal with that every day restoratively. I don't think that's the problem. It's now contaminating the implant and integration and things like that. So I think it's more of a concern.
and again, it's like anything we do. The more material you stick in there, you really, really overload it, then it might push it more apical. If you err on the side of just having enough to cover and connect here, then maybe the risk is less. So there's also, there's a clinical experience with it as well. And obviously your clinical experience is high enough that it's really not been so much of an issue. But the thinking now is not difficult to do. That's why I said if you can do the delayed approach, this becomes much easier for you to interpolate what you need to add and where the contour needs to be. And again, if you're going to err, you err on it being less contour. You're always more safe by less contour, that you know you can always add more and move tissue.
So it's already come up from one individual at the end of yesterday. It's like, hey, the way I do it at home is using Copyplast, using that bicicryl tooth, right? And I said you could use the natural tooth, you could use a denture tooth, you could use a bicical tooth, you could do this technique. We are actually going to do this technique on the molar on our models. So I try and introduce lots of different options so you have that experience, because You may have the preference of always doing it this way anteriorly, happy day, but at least you now have more tools in your tool belt that you can use.
Okay, so same idea. I want to make it out of occlusion, so it's a little bit shorter incisally, but that's what it looks like when I put it in. Now, notice that there is a lot of embrasure space still. The distal's looking quite nice. I leave a lot of space, but watch what happens over the next couple of months after I keep it in. Okay, so here's 2 months, and now I start to have more of a papillary form. But there's still a black triangle, and this goes back to your observation earlier that if you have triangular shaped teeth, you will have a black space. And if you don't accommodate it by addressing it on the adjacent tooth, you end up having to morph this over, which now has asymmetry with the other tooth, and you still might end up having a black space, it just might be smaller. So my plan is to redo this composite to get this shape to match the implant crown. That was always the plan. And so here's now the abutment. This is a metal ceramic abutment, and the composite has been redone here, but now we have our papilla peak and the final implant restoration with just direct composite on the other tooth, adjacent tooth. And this is something that I find that I have to do a lot. I have a lot of patients with triangular shaped teeth, but I also have a lot of patients, maybe you've noticed this, where you have two centrals that are just different widths. It's amazing to me how often I see two natural teeth that the widths are off by 3/4 of a millimeter at times.
Yeah, it's frequently has to be addressed, and I'm just like Greg. If I refer to it, if it's a one-dimensional problem issue, you just do direct bonding. If there's an aesthetic complication overall, yeah, veneer, crown, whatever your choice might be. But the key element that we're trying to address is we frequently talk about contact point relative to bone, but most importantly, it's decreasing the volume of space that allows the tissue to move more coronally. It's not just the point. If you have a very wide space, it's not going to move. So decreasing the volume of space is the critical element. And so whether it's the composite or the provisional, that's what you're thinking about.
Okay, so using those examples, our goal was to illustrate that the end point is what we're trying to achieve. And there's multiple ways that I can get there. There's multiple techniques that I can use. And we choose the technique based on the clinical situation, based on the patient. And I can get to the same end point regardless of how I do it. So I choose that, how is it going to be the most predictable given what I start with.
This particular patient, I'm concerned about the frenum pulling tissue back over time. Why wouldn't they have done a little bit of a frenectomy when they did the
Yeah, you could make that point of if you're in there to do the procedure, why don't you fix this at the same time? I don't have an answer for you. I would say that the surgeon decided that there wasn't, even though there's an attachment, if you were to lift the lip, there's probably not a lot of pull on the soft tissue. But if there was, the risk would be that could move the soft tissue apically over time.
Bob,
Yeah.
maybe, I don't know, both of you could talk about this, but if you're having like a 3-3 Strawman or something and you want to use like a zirconia style, which is not really indicated, what's another strategy abutment-wise?
Perfect question, because the question relates to abutment choices. And that's going to be our next topic, but we're going to do that after the break.
Yeah,
So
it's
before
a great lead-in question.
Yeah, exactly. But I think there
We'll
was
pay you
one more
later for
question
that.
that was coming up. Did you raise your hand? Yeah.
Just back to that, go back to that photo.
Yep.
I'm just being hypercritical here, but, is there any way, it seems to me that even in the temporary and in the final, there's still some asymmetry on mesial and 9 of the tissue. It's almost like 9 is too far on mesial. Is there any way to avoid that, or is that just?
This contour here. Yep. If I was a more talented clinician, I would have caught that. And it's easy. I'm kind of being funny, but it's easy to see it now, but to see it clinically is quite challenging because it's such a small amount of change. But yeah, if you want to be hypercritical, that's something that was my error in the initial adjustment. Now, it was probably in the temporization. The difficulty that I had is I didn't have this contour when I was actually making this contour. So you could say that I missed it twice now, right? I missed it in the provisional, and then I missed it when I recreated the contour here. This is going to be more difficult to do because I have to work subgingivally. So that was the challenge, is I have two different contours coming to the mesial that I'm making at two different times using two different techniques. And given my skill level, yeah, I missed that emergence. But you're absolutely right.
Is that the final restoration, or is it the abutment that caused that?
It's probably occurred in the provisional, and then it was just matched into the final restoration.
Or you can always blame the lab, and they over-contoured. So that's typically the case.
But it was present in the provisional.
For closing thought on this, though, because everyone is here because we're trying to take everything to, hate to use this word, but perfection, right? We're trying to work with super high precision, so when we magnify these on a screen, and now a 1/4 inch tall tooth is now 4 feet tall, and we can see things. So I always go back to clinically acceptable from a social distance and a smile, right? And I would argue little imperfections makes it more believable and more real. If I restore teeth and everything is lined up like a picket fence and everything, it looks artificial. But in this case, I would argue this is a better tooth form based on laterals, and this tooth is the one that I would alter the length on, because if I look at gingival levels, that's how you could then argue the case a little differently.
Yeah,
For the symmetry of the case, I think the final crown is better, right?
The other challenge is the facial concavity, right?
Exactly.
And again, you can try to recreate that in the provisional. I can put a concave surface at the same area, and the tissue will actually fill it in, and you can almost try to emulate it. But again, now that's just another piece that throws our eye off. Now, Bob, makes a good point that, yeah, we say that these minor imperfections make it look real. It's what we tell ourselves to allow us to sleep at night, because I don't think either of us, well, maybe you do, but I know every case that I've ever done, you might look at it and go, wow, that's great. And I'll look at it and find 3 things that I would do differently next time, right? Some are in my control, some are in the technician's control. And I have some cases that I think are really pretty, but I go, this is what I see, right? You're always trying to
You're
improve.
always pushing the envelope to improve, and again, that's why we're all here. That's why we love to be with you guys, because you push us to become better. And we are trying to, most importantly, do things predictably. So you look at all these cases, and we want you to believe you can go home and do this if you follow the protocols and thought process that we're setting up. Because the real world is, right, a lot of this stuff is not done. And then restoration of implants can be super complicated, and it's all in the lab hands, and it's almost a crapshoot, right? And that's super frustrating, I'll say, from a lab perspective. Because in the real world, I'd say, it depends on the lab, of course, but on a real world perspective, 95 to 98% of the time, nothing is set up for the lab. It's all now created in the lab. And so you guys are all here because you believe in doing this, you want to do it because you want these outcomes. So that's the beauty of what we're trying to emphasize.
What I appreciate about your statement is that you see it,
Yeah.
right?
Yeah.
If you don't see it, then you have no way of correcting it. If you're looking right now and you saw that, then that means you're looking at these minor details that will actually help improve you when you get back to the practice.
Yeah.
So that's great. That's great. I mean, pointing out my imperfections, maybe, no, I'm just kidding. I'm just kidding. I do appreciate the fact that you actually see it, because it's a good discussion point. No, it's perfect. It was great. Yeah, that's what we would hope, because that's the way we beat ourselves up.
It seems like oftentimes, even when I use like a really talented lab, and I use your lab a lot, Bob, but
I'm not quite
But when
sure
they're
how
using the
that's-
really talented lab,
I meant a very talented. The central incisor will come back and it's like I need to knock like a little bit of the glaze
Yeah,
off
yeah.
because it seems like maybe getting like this is so great because you're able to dry it off and the surface texture really matches well, but that's really difficult to do.
it's amazing. So his question is, and I think this is very true. If you're like a digital dentist, like a CEREC user, then you're handling ceramic and you have maybe more comfort. But I think most clinicians, you get the crown back and you go, well, that's the technician can do contour better than me, and I don't want to touch it because I might mess it up. So you go, well, it's a little shiny, it's a little dull, it's a little this, it's a little that, and you go, well, let's just put it in. Right? I don't want to send it back to the lab because then I'll lose production time and so on and so forth. We used to have a course that was basically, to your question, it is not difficult for you to enhance the surface. And you'll find that the one thing that technicians actually struggle with is getting the ideal surface, shine, texture, luster, because they're looking at a photo and they don't actually see it right next to the tooth. So that's something that's easy for us as clinicians to do. And what I would say is that grabbing some of the instrumentation and taking old crowns and actually playing with an old crown allows you to do it on this when you're trying it in and know that you're not going to mess it up. And you can take and just minor fluctuation. I mean, it's rare. I work with really talented technician. My technician is phenomenally talented. And Bob has a lot to do with that because he worked with Bob and Bob helped to train him. But it's rare that I don't do something to it. It's rare that I don't touch it. I always will do maybe it's a pink wheel. Maybe I take it to the lathe and I use a little pumice on it to change that surface. But you have to because you're seeing it right next to the natural tooth. Do you want to add one piece before we sign off?
Great discussions. So we're going to move into a break. So thanks for watching on Facebook Live, and we'll see you guys in 15 minutes. So a couple minutes after 10. So we'll see you in a little bit. Thanks.